Darryl Francis. Now, there has been considerable exchange of emails about the motion that they would like to discuss. And this is the one that's been agreed. This House believes renal denervation is the most significant advance in the management of resistant hypertension and should be used in the NHS. And I haven't had a chance to discuss this with Darryl, but I did discuss it with Mark just now, and we thought we'd have a straw poll from the audience in advance of hearing the arguments for and against. So who would actually support this motion as of 9:35 on the 9th of September 2013? I think we'd say not many. All right, well, we'll hold on to that. And as I've said, Mark, you need no introduction. It's a great pleasure to welcome you to our meeting and to hear you lead off our discussions. Mark.
Well, thank you very much, Tony, and thank you to the Society for asking me to be involved. Could I have my slides, please? So Terry was just telling me that as a former secretary of the British Cardiovascular Society, I'm delighted that the British Hypertension Society has now become an affiliated group. I'm sure together we are stronger, so that's a very good piece of news. So here's the motion, and I suppose I should declare if I have any conflicts. I don't perceive I have conflicts, but you're the perceivers. I am, in fact, part of the UK Renal Denervation Steering Committee, and I'm negotiating with various industry partners to fund the national registry that's proposed. I am certainly not an expert in hypertension, and just looking at that vote there, I can see that we've got a somewhat sceptical and hostile audience. But you are, of course, the society that is upholding the best care to patients. You are the patient's advocates, and therefore you should be very interested in any modality of treatment that gives your patients a better deal. I should declare I'm a cardiologist and an interventional cardiologist to boot, but I do not do renal denervation, so I'm completely the wrong person to be talking. And the other problem is, of course, that Darryl is much smarter and much more eloquent than me. On the other hand, I'm told he has a robust style of debating, but we should also remember that Richard Nixon was a robust debater as well. So he's going to concentrate on the case against renal denervation. He's going to tell us that the epidemiology is not fully evaluated, that the number of patients who might be candidates is low, that the appropriate technique's probably not been fully evaluated, that there's inadequate trial evidence, that there's clear evidence of non-response in a significant proportion of patients, there's no evidence at all for non-resistant hypertension, there's no longer-term efficacy data, there's no data on reduction of clinical endpoints, the longer-term risks have not been elucidated, there's no cost-effectiveness data based on hard clinical endpoints, it's expensive, and it's unclear how it will stand in relation to other treatments. So that's Darryl's talk, but I could argue, on the other hand, the epidemiology is becoming clear, that the number of patients is low, but they do exist, that their techniques are being fully evaluated as we go along, that there is clearly a growing body of trial evidence. There is evidence of non-response, but it's relatively low. It is true that there's no evidence at all for non-resistant hypertension, but the window is already being modified in the trials that have been designed, and we do have data out to 36 months now, and it is true we don't have data on reduction of clinical endpoints at this point. There are cost-effectiveness models, and I'll touch on one of those, and it is true I'm not sure how it stands in relation to the other treatments. So we know, I don't have to tell this body, that hypertension is common, it's bad for you. We think that about 10% of hypertensive would be classified as having resistant hypertension, and we know that it's particularly a problem in the chronic kidney disease patients. So if we take, for example, the REACH registry, and we look at the 4-year outcomes of patients who were defined as having resistant hypertension, and you look, if you like, at the surrogate of their treatments, the worse, the higher the number of the drugs you have to take to try and get control, the worse these patients do, with about one quarter to 1/5 of them having a major event over the next 4 years. So this is a bad risk group. It's defined as failure to treat hypertension successfully with 3 or more drugs, one of which should be a diuretic. The series suggests that it's between 5 and 50%, but it's more likely to be about 10%. And of course, we don't need to tell this audience that they have to be fully worked up. And not only drug-induced hypertension, but secondary hypertension has to be excluded. Here's one particular study on an outpatient group from the States, 468,000 patients with hypertension. About a third of them were uncontrolled. The definition was a diuretic and at least 2 or more other classes of drugs. And a third of those patients were on 3 or more drugs, so they probably reflect the resistant hypertension population, although only 15% were on optimal treatment as defined. It is interesting, of course, as Mel's mentioned, that there are a lot of patients who do try to take a lot of drugs and just can't tolerate all that you offer to them. And interesting, in this study, actually, the physicians seem to be trying harder on those patients who are at greater risk, so the black race patients, chronic kidney disease diabetics, and CHD patients all were more likely to be on optimal treatment. So Mel has given us an overview of the non-pharmacological armamentarium, and there's a few others to add to that, as he's pointed out. So I'm simply going to talk about renal denervation, and I'm not going to spend a lot of time on the theory behind the importance of the sympathetic nervous system in both the initiation and perpetuation of hypertension, but that the modulation of this reflex through renal denervation can lead to a significant reduction in blood pressure. We know that the renal sympathetics lie in the adventitia of the renal arteries, and we know that if you do renal denervation in pig models, that you do actually ablate and damage the adventitial arteries. We know that renal denervation in this particular case report does have an effect on terms of renal and whole body norepinephrine spillover, and also in muscle sympathetic nerve activity is reduced. So seems to be a systematic effect of renal denervation. That has been shown in much larger studies of patients, so it's not a single case report. The procedure itself is relatively straightforward. You stick a tube up the femoral artery, go into the renal arteries, and then use an ablation technique. It can be painful for the patient, so they need some sedation and analgesia. It can be, in individual cases, associated with immediate hypotension, but that's actually unusual. There is a potential for complications, but they happen very infrequently, and there's also potential for bleeding. But interventional radiologists and interventional cardiologists have had years and years of experience of getting in and out of arteries. So most of the data comes from the Symplicity clinical trials program, with the first-in-man studies and the Symplicity HT1 and now the HTN-2 study, and this is using what was the RD and now the Medtronic Symplicity catheter. You could see that the patients were predominantly Caucasian in this particular study and had severe hypertension with mean baseline blood pressure of nearly 180/100 and on 5 or more drugs. The 2-year data is out, and we can see that there is a progressive over time impact on the number of patients who get classified into various blood pressure groups. And if I can move on, there's this interesting phenomenon that actually there's been a slight increase in the progression of blood pressure responders over time. And if you are a non-responder at 1 month, wait, because some of them do become responders over 6 months to 1 year. The Symplicity Hypertension 2 trial was 106 patients randomized, and you can see both at, I don't know if I have a point here, but at the 1 month, 3 month, and the 6 months, there were good blood pressure controls with absolute differences which were quite impressive compared with a lot of drug trials, and at the expense of no significant renal dysfunction. In fact, there are other studies to suggest that there may well be an enhancement on renal function and a reduction in microalbuminuria. We now have the 1-year data published in Circulation, and we can see in the renal denervation group over on the left-hand column there's a reduction that's been sustained out to 1 year. We now have 36-month data from some of these patients in Hypertension 1, and also they had a crossover group of 35 patients that they were offered renal denervation, and having been resistant, up to the time of crossover, these patients also got a significant reduction in their blood pressures. In terms of medication changes, we can't give a message that this is going to be a way of getting you off your tablets, although there is about a 1 in 5 chance that you will have a reduction in your doses over 1 year. And there are 1 or 2 patients, particularly those who don't respond, who are going to have an increase in their medications. We're awaiting the results of the Symplicity Hypertension 3 trial. That's 500 patients that have been randomized in the United States. And it's not 100% a sham procedure, but what they're doing is randomizing at the time of renal angiogram. And the patients are all given pretty heavy-duty conscious sedation, and also they're put into a sort of sensory isolation. They're going to have music piped into their ears and various other things to try and make sure they don't actually know what's happening in the lab. And they'll all be given sedation and analgesia, so they don't know whether they've had a denervation or not. I suspect that won't work completely, because I suspect those people who've had ablation will know about it. However, it's a good attempt to try and do a sham procedure. There are other devices, so here are the ones that are sort of becoming more into use, but there are about, I'm told there are about 50 companies who now have an interest in trying to design one of these catheters. There's already a first meta-analysis of the trial results, and no doubt we'll see a sequence of meta-analyses over time. But if you look at both the 3-month systolic and 6 months, you'll see a progressive increase over time, and also the similar in the 3-month and 6-month diastolic numbers as well, also increasing over time in all of these studies. That's in the control studies, and similar results reported in the uncontrolled studies. We now have the results from the Enlighten-1, that's a subdued catheter, with again significant reductions in blood pressure over the period of the duration of the study, 6 months. And you can see that the majority of patients were responders, although there were a significant but small number of non-responders. And we also have the 12-month results of the Covidian one-shot device, and again pretty impressive office readings, although if you look at the ambulatory blood pressure responses, it's somewhat, those results are a little disappointing. But so far, these devices do seem to have an effect in some of these patients. So we have evidence of efficacy. What about cost effectiveness? We don't have any long-term studies, and we won't have for many years, so we have the only way we can do cost effectiveness is on models. And this is probably one of the best ones that have been done. This is looking at a 10-year lifetime, 10-year and a lifetime model, looking at a Markov model, looking at the perceived reductions in events that you would get from the magnitude of the blood pressure response, and on this model, even a mortality difference. And this comes out with a cost per quality of only $3,000. So that's a highly cost-effective strategy. And in terms of the probability sensitivity analyses, a 97% chance of this being a cost-effective treatment with a $30,000 per quality window. It's been mentioned that there have been reports, or in fact a report of renal artery stenosis late on, and to my knowledge there is only one report in the literature. If you look at the Davis meta-analysis, in fact, in those 500 patients in that study, there was 1 renal artery dissection and 4 pseudoaneurysms. Most pseudoaneurysms can be avoided, but there will be a few of these, and they can be treated pretty quickly and easily. What about non-responders? So actually in the studies it's between 8 and 37%, averaging around about 20% of cases. So the question is that in those patients it may be that the subordinate relevance of sympathetic activation is not the right strategy, or what's not the main cause of their resistance. It could be there's been inappropriate patient selection, and there is a concern that if you give a CE mark to a device, and particularly allow it to let loose particularly in Germany, then it will be used. And I think we will see inappropriate use of this technology, but not in this country, I don't think. Is the procedure ineffective in some people? Well, that's to be determined. And do patients think they get cured from hypertension afterwards and stop taking their drugs? I think that's something that we're going to have to watch. In terms of identifying people who will respond or not, then all we have at the moment is a marker that the patients who have the highest blood pressures before treatment seem to be the most likely to get an effect, and those patients who only just sort of sneak into the group get less an effect, but they are still getting an effect. The other thing is people have looked at whether heart rate should be an indicator, and in some studies that's been suggested as a potential for response, but in others it hasn't been confirmed. So how do we get this technology into the UK? The commissioners, when we started discussing this with them a couple of years ago, felt it was expensive and that overall the health gains were uncertain. So their general view was that widespread use of renal denervation was not yet justified. Now, normally in the UK, what happens is a couple of important or self-important centres who have a little back pocket of finance can buy some of these things in and start playing with them and then wander around the world with a few abstracts. But we then wait till international studies. NICE eventually, about several years later, takes a look at it, and even when NICE says you can use it, there's around about a 5-year window before it actually starts to be propagated. And so, actually, in my view, that is not a really good way of getting new technologies, particularly when you feel the evidence base is not so secure. So we have been attempting another route, and so over the last really about 6 years, 4 to 6 years actually, we've been talking to the NHS about getting new technology into the system, and we have got them to agree to a concept that has now been referred to as commissioning through evaluation, and they are buying into this concept. So that they will commission as long as patients are taking part in either in a study or in an observational registry. And that requires the development of a registry and an encouragement of UK participating centres to participate in both national and international research. So we created a steering group that's been chaired by your former president, Mark Caulfield. It has all the relevant stakeholders, although I think the British Society for Heart Failure should also be involved. We have come out with a consensus statement, as you know, and we've got recommended criteria, which in effect are the inclusion criteria for the trials, except to make it even tougher, we've said they've got to be at step 4 in terms of the NICE British Hypertension Society algorithm for treatment, so they've actually got to had a 4th drug added. What have NICE said? Well, they reported back in January last year. You don't have to read all of this. They did say that there was some evidence, but not enough, that there were governance criteria to undertaking a new technology, and that patients must be informed about the uncertainty of the long-term effects, that a multidisciplinary team should be involved, and that hypertension specialists should be involved in selecting these patients. Further research is encouraged, but also NICE encourages data collection and publication of outcomes, so clinicians involved should submit data to the National Registry when it becomes available. Well, we do have the National Registry virtually ready for launch. The dataset has been agreed. It's been designed in classical audit domains to give us evidence on safety and efficacy over the longer term, but it also has the potential for a research, supporting observational research, and there is also actually potential for randomising through the registry. It's an easy-to-use web-based system. It's been tested. Mel, for example, was one of the ones who's tested the system, and the obligation on those centres who take part in this will be to provide long-term outcome data. At the end of 2012, there were already 19 centres, and it's probably more than 20 now, who have already got some experience in renal denervation. Not that many cases, about 150 last year and about 30 odd the year before. So it already is being used. The commissioners have been a little bit confused, however, that in December 2012 they did come out with a statement that the commissioning board would support renal denervation, although they also said that the mechanism funding was yet to be confirmed. And then in April this year, they then said that renal denervation is not routinely funded, but in fact what they really meant was it's not routinely funded, but they will support it through commissioning through evaluation. They've now made a formal declaration that commissioning through evaluation will take place, and so some designated centres are going to be asked to take on this treatment. And my view is that the joint societies should be involved in trying to create a system of cross-referral to those participating centres. So I'm going to conclude to say that I think resistant hypertension is a real problem. It carries significant long-term risks. It occurs by definition in spite of the treatment strategies that you've got available, and that renal denervation has been shown to significantly reduce blood pressure in a significant proportion of patients. It's safe, it's effective, it's probably cost-effective, and although commissioners have not been persuaded that it should be routinely available, they have decided to support the commissioning through evaluation framework, and that we do need to get the clinical networks to start referring appropriate patients. So I think it is certainly one of the most significant advantages for this particular patient group. It's already being used in the NHS, but we need to get that into a coordinated form through the commissioning through evaluation framework. There are trial data to support what we're doing so far, and they will help shape future commissioning decisions. So I would suggest that you should support this motion and that we should have this treatment available. Thank you very much.